Hai Kwe, and welcome to this very special edition of Conversations in Canadian Bioethics, les conversations sur la bioéthique au Canada. This session is looking at ethics and trans people's healthcare in Canada, or l'éthique et les soins de santé pour les personnes transgenres au Canada. There are many ways for you to join the conversation today. We are very pleased to have simultaneous live translation available in English and French. So if you look at the ribbon for your Zoom, you will see an interpretation that could perhaps be behind the more, the 3 dots of more, or it might be right there on your ribbon. If you choose one language, for example, English, then every time a speaker is engaging in French, you will hear the translation. And when the speaker is speaking in English, you'll hear the original, and vice versa for if you choose French language. We also have closed captions that you can turn on for this event. And we also are going to be taking questions via the Q&A button. You can ask your question in English or French, whichever is most comfortable to you. And we will not read your name aloud. However, people will be able to see your name on the screen once we answer your question, but this will not be part of the recording. So we welcome any feedback that you might have for this session, and you can provide feedback at administrator@CBS-SCB.ca. So as I mentioned, this meeting is being recorded, and that recording will be on our CBS YouTube page, which we can link through the CBS website that you see at the bottom. And we have a new website, which is very exciting for us. This website allows a lot more functionality than our old website. And this is now live, where you can find out all about the Canadian Bioethics Society, la Société, canadienne de bioéthique, and all of our events are listed there. You can also sign up to become a member of the Canadian Bioethics Society on our website, and we have both individual and organizational memberships. One of the big advantages to being a member of the Canadian Bioethics Society is that you get to network with peers in a supportive environment, and you can collaborate with others on important bioethics issues. The new website also includes new features such as the CBS membership directory, so you can find people who are working on issues that interest you, and a resource repository where we put all kinds of resources related to healthcare ethics and clinical ethics consultations. We also have new interest groups that launched at this very forum, and if you're a member, then you can sign up for those as well. And you get reduced rates for all of our events, and you can serve on the board, and you can participate in our business meeting where you get to vote on the direction that the Canadian Bioethics Society will take. For organizational members, all of the individuals within your organization will get access to the individual benefits that I just mentioned. In addition, organizational members get to be a part of the Leaders Forum, which fosters networking among bioethics organizations across Canada and helps us to coordinate projects and initiatives of relevance to the organizational members and the bioethics community. The individual members within the organization will also get one free membership for one member and reduced rates for all of the members and the employees of the organization. In addition, the organizational members can post job postings on the CBS-SCB website, in our newsletters, and on our social media sites. So this can help you promote any jobs that you have available. And finally, the organizational members will get acknowledgements on our website and at our major events. So I would like to open this session today by giving a land acknowledgement. We're coming from across Canada today, so from a very diverse number of places. I am coming from Adjunct or Montreal, which is the area that I work and live in at the moment. And I think it's important to think about how the land is the basis for all relationships, knowledge, experience and our experiences of health and well-being. So without the land, we don't have anything. The computers that we're using to greet each other today are made of materials from the land. The food that makes up our bodies comes from the land and helps to power our thoughts and our emotions. And so Tugtage is a gathering place for many First Nations, including the Anishinaabe, the Huron-Wendat, the Abenaki, the Haudenosaunee, and the Canadian Nation. So today it is a home to diverse populations of Indigenous, Quebecois, and other people. And those of us who wish to live here ought to ensure that we respect the relations among the lands, the waters, and the people in a spirit of peace, friendship, and well-being. So today we are going to look at ethics and trans people's healthcare in Canada, which backstage George and I have been calling advocacy amidst turmoil, lessons from the trans community, or la mobilisation en période de turbulence, les leçons de la communauté trans. And this is in keeping with our forum theme about bioethics in turbulent times. So our speakers today include April Otero, and she is an educator with Le Mouvement Transféministe. She is a feminist sociologist and social researcher, and her areas of research interests include sociology of science, feminist epistemologies, social theory, and sex industry and prostitution studies. So welcome, April. Nous avons aussi parmi nous Judith Lefebvre.
We're also welcoming Judith Lefebvre, who's an author and trans-feminist activist. And since 2022, she's co-founded a number of initiatives on contemporary queer and trans writing, including the trans feminist movement. She also has a biweekly column online. It's called Pivot.
And our third speaker is Florence Ashley, an award-winning trans feminist jurist, assistant professor, bioethicist, public speaker, and advocate who moves through academia using a profoundly transdisciplinary approach. Florence is the author of the acclaimed book, Gender Fucking, The Pleasures and Politics of Living in a Gendered Body, published in 2024, and Banning Transgender Conversion Practices, a Legal and Policy Analysis, published in 2022. They are also the author of over 30 refereed academic articles and chapters in academic journals, and their work has been cited by the Supreme Court of Canada, the United Nations Independent Expert on Sexual Orientation and Gender Identity, the World Professional Association for Transgender Health Standards of Care, and in position statements, reviews, and guidelines by Australian, New Zealander, Canadian, Polish, German, Swiss, and American professional and state organizations. Leading our discussion today will be George Magafas, who is a student member of the Canadian Bioethics Society, and he is a member of the New Initiatives Committee along with myself. He is pursuing his master's degree in public health, where his bioethics interests include LGBTQ plus healthcare and equitable access to care and intersectionality. So please join me in welcoming our speakers. And I'll turn
Thank you,
it over
Meredith.
to you, George. Yeah.
Yeah, thank you. I would also like to acknowledge my position on the traditional lands of the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat. I'd also like to acknowledge that this is a timely yet contentious topic. I ask everyone in the audience to remain respectful, but above all else, to be open and curious to the discussion. So we can jump straight into it. And if any of our speakers would like to kind of take a stab at defining what gender dysphoria is, and what the benefits and detriments of using gender dysphoria as a diagnosis are.
Hey, I can take this one. I can break the ice. So gender dysphoria is very simply put a diagnosis tool. Actually, it's a diagnosis that's part of the DSM-5. I see it as an direct descendant from transsexuality, actually, that was proposed first in 1966 by Harry Benjamin, as we know. And it is kind of I call it a bastardized version of transsexuality because it creates so transsexuality, for those people who don't know, was a very, very thorough and very complicated diagnosis. It was very hard to get. And so it implied to like go through lots of hoops and loops, and specifically to put your own personal narrative in alignment with the diagnosis tools. And so that's why also we very early on as trans women started like sharing this resource that is a transsexual phenomenon. That was a book that was published in 1966 to align ourselves and our narratives with what is transsexuality. So in order to have access to care, to have access to bodily autonomy, and to have access to the social mobility that transsexuality promised, right? And gender dysphoria to me is kind of the it's the a diluted version of that. Basically, is like we, as Susan Stryker very eloquently puts it, like the monsters speak, right? Like as soon as we were created as transsexuals by the medical profession, we started having our own interest in speaking our own interest and speaking for ourselves, and we asked for depathologization very early on. And as such, the medical profession started to wind back on the diagnosis the more and more and more. And so we end up with this version that we have now in the DSM-5 that is gender dysphoria. And gender dysphoria, simply put, is basically, if you read the definition, aligning, identifying to a gender that was not the one that was assigned to you at birth. Basically, that's the basic definition of it in the DSM. The more important diagnosis tool actually is the fact that it must create a clinically significant distress in the patient to be diagnosed with the gender dysphoria, which is, of course, tautological, because if you align with a gender that's not the one that was assigned to you at birth, and you are not diagnosed and therefore cannot access care, you will probably develop some sort of distress at that point and then become dysphoric in accordance to the psychiatric tools. So that's basically the definition of gender dysphoria as I would put it personally.
I like to compliment what my colleague just said. I pretty much agree with everything Judith just said. I think dysphoria could be addressed both ontologically and pragmatically. Judith just pretty much addressed it from a very practical perspective. But I think it also has to do with the whole what does trans means, right? So what does that even mean to start with? So most of the times when we're asked, what does feel free to be trans. I do believe that it could come from an innocent place. However, it carries the significant symbolic weight, which is related to the othering process, right? So this is, the person who's presumed to be natural, neutral, and then there's the other person, which in this case are the trans, right? The trans. So it also presupposes that gender transitivity or transitioning between genders, or even experiencing shifts within one gender over the course of a life, it's something that is only exclusive to trans people, and that is false. So instead of, me personally, instead of taking a position where I feel the need to prove the legitimacy of my own existence, which is why, proving others why I'm trans or why am I a woman, I prefer to kind of turn the tables or turn it around. So I like to ask others, okay, so what is it like being cisgender for you? Or when did you realize you were a woman or a man, right? Depending on each case. Now, dysphoria, ontologically speaking, I'm not going to dive into it that much, but I'll have to disagree from a radical feminist approach with the whole I was born this way narrative. I know Lady Gaga said that we were born this way, but no, we sociologists are very careful with this biological determinisms. For us, as sociologists and feminists, we don't believe we were born this way. Instead, we like to emphasize the autonomy of our decisions. So for me, gender dysphoria, and for me and for most of us actually, it's a very strategic platform, but it also has some risks associated with it. And, one of them is the fact that it reinforces the myth of the perfect victim, right? The myth of the perfect victim that is a concept that the feminist scholarship has vastly discussed, the victim needs to be credible, must have no motivation other than the truth. The truth must be obvious. And more importantly, we as victims need to be likable, right? So I think that it's a way to complement, the ontological part of it, of what just said, just to keep in mind what trans means and the fact that we're talking about transness from a very Western and white and, contemporary perspective. Because again, gender transitivity is not exclusive to the trans people again.
I want to build on that and kind of reinforce the point that I think in many ways, gender dysphoria as a diagnosis, not necessarily as a concept, but primarily as a diagnostic category, primarily exists for cis people. Like its primary function is not actually about trans people, but rather about naturalizing being cisgender, about making cis people feel secure in their gender by saying, well, those are weirdos. You're normal. So like, don't worry about it. But then that, in many ways leads to the practical problems associated with it, which is not just, yes, the process of gatekeeping, of course, but just like the very criteria that are part of the diagnosis. Frankly, it was like it was written by somebody who never like talked to a single trans person, but like read about them in a book and then like decided to come up with a list of criteria. And it's simultaneously like over-inclusive and under-inclusive, which makes it completely useless as a diagnostic or clinical tool. Because on the one hand, it's under-inclusive in the sense that there's tons of trans people who want to access gender-affirming care and who may not actually fit all of the criteria or enough of the criteria, in part because of the significant political distress element, but not only because of that, but that's one of the big ones. But it's also over-inclusive in the sense that I can get a diagnosis based on, say, like chest-based gender dysphoria and use that to get genital surgery. Because there's no specificity in that regard. So there's a lot of uneasiness to it, and to a point where, like, especially, to a point where, like, there are ways to actually like fulfill other criteria without actually wanting to have any sort of medical interventions. So, like, it's not really helpful in that way either, and that's why we have, studies that say that say that trans people think that it's, well, trash.
Yeah, and thank you guys for that input. I do want to remind everyone that the Q&A function is open. We may not get to the questions immediately, but if you want to populate them with anything that you think of while a specific section is going on, by all means. And we'll move on. Et maintenant, je dois poser une question en français.
And I'll be asking this question in French. How can gender dysphoria allow healthcare to be covered? Once again, I can perhaps take an initial stab at it. I think we're looking at this from a very pragmatic perspective. And from that point of view, access to the diagnosis in many cases has to be understood as follows. Currently, the dominant model, maybe not the case pragmatically, but theoretically, is informed consent. So to have access to hormone-based therapy, normally we're told in any case that we can go to our family doctor, talk about it, and simply so I just want to make sure that I have my settings right. So we go to our family doctor and say, I want to transition, and we're told about the risks associated as well as the benefits associated with it. And then we get a prescription, we go to the pharmacy, and we can fill it. Then dysphoria becomes useful when we look at gender-affirming surgery. That has to be documented for a period of time if you apply the standards of care. And so the dysphoria has to be documented for a while. So if you can obtain the diagnosis, then you can access gender-affirming surgery. But eventually, what it means also is that the insurer gets a code. Whether that insurer is public or private, they get financial coverage for the care. So that's the main, if not the only, pragmatic use for gender dysphoria, because it allows you to have access to funding for care, simply because of insurance bureaucracy. Even, and that's one of the problems with insurance, with people that want to remove the diagnosis, is that, yes, it was a bit the case in the past when criteria under the International Classification of Disease, I think it's called. I just wanted to confirm my language there. So it was worse in the past than the DSM classification. So before ICD-11, I can't remember what the acronym is, but in any case. So the problem is that now there's a new code. And insurance codes are based on the International Classification of Diseases and not the DSM. The DSM does tell the provider, for instance, this diagnosis corresponds to this code, and that's the code that's in the ICD, but the ICD is the holder of the billing codes. So now that we have this, there's no longer a real reason, in my opinion, to refuse care. And I think that the ICD's new definition is better. That's not how I would have put it, but it's better.
Yeah, and that's great. I appreciate the input on that. Kind of moving on, why do you guys think it's important to maintain access to care, not just in relation to gender dysphoria, but all levels of gender diverse care?
Well, I think in general, as we are now, most diagnosis tools and the way transaffirmative care is treated is actually hindering access rather than giving access to care. And it doesn't hinder only access to transaffirmative care. Actually, it hinders access to quality of care and a good relationship with our care providers. Because of the dynamics I was naming in my first intervention, like we are in this relationship with doctors where they actually hold a tremendous amount of power over us by having this power to actually prescribe or not these various elements of care. And so we are put in this very delicate position where we have to, well, lots of people end up lying actually to their medical professionals about risk assessments, like for example, smoking, for example, drug use or something like that, because they fear that this care could be taken from them. And so if I am honest with this, personally, I think that we should be heading towards a harm reduction approach when it comes to transaffirmative care. That is basically getting doctors out of the gatekeeping process. Because if you look at the standards of care, how they were developed by WPATH, even the last ones, which are way more well documented than the ones before, but even then, you look at it, and most of the documentations is about, are you going to prescribe or not? It's all the focus is on gatekeeping access. And in the end, we don't have a lot of research on the efficacy. We don't have a lot of research on the pharmacodynamics. We don't have a lot of research on the long-term effects other than is it going to kill you or not? And because all the care was basically built around professional liability, actually, rather than quality of care. And so if you look at the global south, for example, people can just walk into a pharmacy and ask for hormones. And the pharmacist is going to make sure that you have the necessary information and you can make informed consent if they're doing their job properly. Of course, it's probably not the case most of the time. But what I mean by that is, like, if we would get other professionals like pharmacists, for example, into this and actually make them more knowledgeable of the pharmacodynamics aspect of the actual substance and the exogenous hormones that we're taking, for example. It should actually raise the level of the care on the one hand, because we would be able to have access to informed consent. Because when we go to our general practitioner, most of the time they will they will not know, and they will either just give prescription because they don't want to hinder access because they're trying to be nice, or on the other hand, they will just refer us to specialists. And if we go to specialists, sometimes it can like end up being very long wait times, and like, so in the end, we are in a position where physicians are kind of bad actors in this whole scenario, actually. And I would like to see like more autonomy in the decisions we make for ourselves and less gatekeeping, because that's the only focus of transaffirmative care since its implementation, really. And it's all hinging on, professional liability. And we're seeing the same thing right now with all these research that we see about regret rates and stuff like that. This is not about us. This is about like medical professionals. This is about their professional responsibility, their professional liability. This is not about us, because we all know when we see these studies, we all know what it means. And so even if we're unsatisfied, we will say that we are because we don't want to lose care. And so it creates this, like the current situation creates this very dishonest relationship, and it actually gets us in a place where we don't receive proper care in many different aspects, and not only transaffirmative care, actually.
I can go on a little, actually, I'm gonna be quick. Why access to care? Because I like the freaks and the weirdos of the world, and I hate empire, because that empire wants us to reproduce a formula of gender that was crafted and specifically designed in service of racial capitalism. And so for me, within that context, to mess with that idea of gender, notably by rejecting this idea of your body has to, never be changed and has to fit whatever gender we want to impose upon you, to mess with that is both a moral and a political good. So it's not just okay to be trans, it's actually good, like politically and morally.
I'll have to argue that. So, not necessarily. We cannot just presuppose that all trans people are revolutionary just because they're trans. That's really not the case. And some people actually just fall into this narrative of the wrong body. And actually, what gender dysphoria does, for the most part, is reinforces this whole sexual dimorphism that says that there are blue brains and pink brains, right? So it's dangerous. It's actually a very dangerous relationship. So we as the movement need to be very careful not to reproduce the idea that just because someone's trans or just because someone, has a gender transition, he per se is revolutionary. I'll have to be very careful with that.
I think that all other things being equal, being trans is not revolutionary good, but you can also have shit takes, like that is something you're not shielded from, and you can do trans in a way that is counterproductive. But I think like other things being equal, between a cis person spreading the same discourses and a trans person spreading the same discourses, I still feel like the trans person is probably disrupting, just by existing the system, a whole lot more.
Yeah, but
Did you want to touch more on that, April, as well?
Well, again, I think that's a very romantic view of trans of the trans stuff, and I respect that. I do. It's just that when we look at the evidence and when we look at, for the most part, how the medical institution has shaped the transness of nowadays, we also need to be very careful. Yes, gender transitivity, I insist, it's not something solely, of trans people. But again, if we're okay, so this as a feminist, and this is my standpoint. As a feminist, we also need to be very careful with reinforcing gender roles. So most of the time, these medical institutions, what they do is to reinforce gender roles. And me, as a feminist, and as a radical a feminist, what I want to do is abolish gender. I don't want to reinforce gender. I don't. I want to abolish genders. I don't want to create more genders to fit into what it should be. Or I want to abolish gender expectations as well. So yeah, that's just my take. It's okay to have differences. We don't have to agree though.
But also, I would like to add that, transsexuality, when it was first introduced in 1966, was a basically a pact, and you wrote about that, Florence, actually. It's basically a pact between, the state and the medicine, basically, right? And it is a tool for basically controlling and normalizing perverts and deviants that were flocking, right, in their cities, especially the US, in the midst of like the urban renewal and everything. And so for one, it is a pact between the state and medicine. And that's probably why we see this crisis right now, right? Because that medicine is basically like leaving its role and just like being like, yeah, we don't want to do that anymore. We're actually, we don't see any evidence that this is a pathology. We don't want to do that anymore. And so the state is kind of like creeping back to be like, okay, but like these deviants need to be controlled. And so they're stepping in, and that's why you see like the backlash right now, and also especially in the UK, how it's rolling out in the US, of course. But yeah, no, I do believe that in its trans by itself, in its origin, is actually very, very normative. And
There you go. There you
that's
go.
and that's basically just by the virtue of existing within the frame of transsexuality that we become actual subjects, and we actually like push back against these criteria, these diagnosis criteria, and just, well, I always refer to Susan Stryker because this is kind of my go-to, but like this is the monster speaking, right? It's like it's just we're this is the whole analogy with Frankenstein's monster. If you don't know the reference, basically like we are a creation of medicine, but we're also able to speak for ourselves. And then just by the virtue of existing, we're actually abolishing the very categories that created us in the first place. But yeah, there's a tension between the two, and it's very hard to just pinpoint, in my opinion anyway, like trans is transgressive or trans is actually normative, because trans medicine is normative, but trans existence are actually always contesting these very categories. So I kind of stand in between the two.
Yeah, I just wanted to add just a little bit just to close my idea. When we look at Julia Serrano's work, because it's just one of my favorite feminist authors, Julia talks about sexualization and how sometimes we believe that the subject of sexualization is very specific. We usually, when we talk about sexualization, we usually use the predator mindset and also the, rape culture, and we usually think of a cisgender women and the sexualization related to the sex. That's how but on the other hand, what the medical institution does is also a form of sexualization. So when we talk about trans patients from these gender, very normative and conservative gender roles, that's also a way of sexualization. Just to give you an example, okay? We have a psychiatrist, talking about their trans patient. And let's say if a trans woman, right? This psychiatric would usually describe their patient from all of these, gender norms and roles. That if he or she or they could be like, okay, so my patient has long hair, wears hair, does makeup, and fall into this very uh shallow understanding of gender. And again, that's also a form of sexualization. So just to complement what we were saying about how the medical institution not only reinforces gender, but also sexualizes the trans bodies in the process.
Yeah, the sexualization is just so weird. Like I remember when I was, trying to get letters for stuff, and this psychologist that I had to get a letter from talking about, how like, and he meant that kind of positively, I guess, but like, how it'd feel if he went to the bathroom and I was like there, but like in a very weird kind of like sexualized way. And it was like super weird, and it reminded me of the fact that like historically one of the main criteria for whether you got to transition was would this doctor fuck you? Was essentially, they wouldn't fully admit it. They'd use, euphemistic language, but that was essentially the criteria. So yeah, it's kind of gross. And I think like a lot of that is fundamentally an attempt to curtail the disruptive potential of, trans existence. But here I think like perhaps it's useful to distinguish between like the existence of trans people as people versus the existence of trans people as trans with all the discourses that implies. Like, because there's a lot of people who disrupt the system like living, but then the narrative that you put onto it in terms of transness definitely don't, right? And in many ways, the very creation of the concept of trans was like kind of serve that purpose. But I also kind of think about this this study that I found quite interesting about public perception in terms of like a disruption of gender norms of both trans people who like conformed with it was only on kind of trans women and trans men. It wasn't like non-binary people, but who conformed with their gender and those who were more non-conforming. And interestingly, both similarly disrupted and disturbed people's ideas of gender. And so, but it goes to kind of the issue of like, is trans disruptive, is trans normative? And I think the issue is that it's both, because whenever you have these narratives come out, they fundamentally exist as a sort of compromise, right? Like you had a group of people who wanted certain things, and there was a system that didn't want them to get any of those things. And the system compromised by saying, if we frame it this way, and we let this group do certain things, then we'll give you what you want. And so there's this constant tension between kind of cis normativity and the idea of like everybody has to be cis, and trans normativity, which is this idea of like, oh well, there's one right way to be trans, which is fundamentally a sort of like compromise. And ultimately, and in line with what April was saying in terms of abolishing gender, the goal is to shed both of those and actually make way for a world that's actually liberated from that.
Yeah, thank you for that. And we will kind of touch on a lot of the things that we've already spoken about in terms of passing and things like that as well a little bit later on. Et maintenant, comment les soins de santé transgenre sont-ils contestés dans
How
votre
do
région?
transgender healthcare services are challenged in your region?
Je suis en Alberta. OK.
So I am in Alberta. Oh, okay. I'll go first. I live in Alberta, where we had the first piece of legislation to prohibit access to gender-affirming care among young people. And this is really part of a whole array of regressive legislation in Alberta that aims to that takes aim at sex education. I think it's a very slippery slope, and we're starting to see pieces of legislation with lists of books that are not allowed, that should not be allowed in schools. So for me, here is the irony, because you're not allowed to have certain books because they're deemed inappropriate for young people, but they're trying to put Bibles in classrooms, while the stories in the Bible can be way more graphic. So there is pressure in Alberta that's reminiscent of what we're seeing south of the border. I think challenges to healthcare for trans people is broadly inspired by what's going on in the United States, but I think in Alberta specifically has some sort of an attachment very unhealthy attachment
politique américaine,
to US
au point
politics,
où, genre, Daniel Smith va à Breitbart, qui est
to the
un
extent
média,
that
tiré
Daniel
pour
Smith
le
attends
pas Borderline, je dirais, mais
Breitbart Institute
puis
meetings,
c'est juste comme, c'est comme ça qu'a fait la politique.
which
tu sais.
is basically
Donc,
a Nazi
je pense
institution.
et d'où
And that's how she
l'importance
does
de souligner à quel
politics.
point ce sont
But
des luttes,
hence the importance of
qui-
highlighting the
vraiment
fact
qui
that
transcendent,
this goes
tu sais,
beyond
nos tentatives de dire, ça c'est juste pour les personnes trans, ça c'est juste ci, ça, c'est
being
mis
just
ensemble
trans or
et
being just
d'où
cis.
besoin de faire lutte solidaire,
It
faire
needs to be
lutte solidaire.
taken together, and we
Je pense
need
que l'Alberta démontre ça
to be
vraiment, puis
in
on voit ça
solidarity.
venir
I
de
think
comment les autres
Alberta
pays aussi, donc,
is
en
very
espérant qu'ils réussissent
obvious,
à abattre ça.
but I think it is present everywhere in the country.
De notre côté, au Québec, parce que je parlerai pour le Québec,
On the other hand, in Quebec,
on va recevoir demain matin
since it's where I live,
le rapport du comité de
tomorrow
stage
morning
sur les
we're
désordres
going
et on vient de
to
savoir une heure
receive
sur la
a
comité de
report
à 11 heures, donc on va passer par
from
là.
the Committee
On a
on
bon espoir que
Gender
ça
Identity.
trop l'accès aux soins,
So it should
mais
be published tomorrow morning at 11. We think it's not going to affect access to care too much, but we'll see.
Les soins affirmatifs en ce moment, les soins transaffirmatifs,
Gender
ils sont
affirming care
dépassés
right
et
now
contestés de toutes parts.
is being
Sont contestés
challenged
puis dépassés d'une part,
on
oui,
all
par
sides.
effectivement ces
So,
tendances-là qui veulent s'attaquer
by people
principalement à la profession
who
médicale.
want to attack
Mais d'autre part,
the medical
par notre
profession,
communauté, tu
but
sais,
it's also being challenged by our own
l'historienne
community.
Peterson qui avance en fait fort
Bill
probablement, et
Peterson,
j'ai tendance à être d'accord avec elle,
historian,
la plupart des femmes trans, au moins, je ne sais pas pour toutes les personnes trans, mais
said that
les femmes
most trans
trans
women, I don't know
ont
about
transitionné par leur propre
trans
moyen,
men, but
historiquement.
trans women
Et donc,
traditionally
une contestation aussi
did their
difficile par
transition by their own
rapport à- il y a
means.
un
So
accès qui existe aux soins
there
transaffirmatifs
is
qui ne dépend
access
pas des
to
médecins.
gender
Et
affirming
entre ça,
care
il y a aussi une
that is not does not depend
communautaire des
on
soins transaffirmatifs, où les
physicians.
gens se
So there's a
ramassent de différentes
community
manières.
aspect of
Je le
accessing
constate autour de moi, moi-même.
gender affirming care. I can see that around myself.
Mes propres hormones que j'en acquiers pas.
I administer hormones that I do not get through my doctor
Pour un ensemble de raisons, mais
for many
et
reasons.
donc, il y a cet enjeu-là qui se joue. Quand on parle de contester
But
les
so,
soins d'assurance affirmative, il faut quand même penser ça de façon,
there's
je pense,
those
un peu
dynamics.
plus
So
générale.
we have to think in a broader way.
Quand on regarde la question, nous, on aime beaucoup la notion, je ramène constamment la notion d'autonomie
I
corporelle.
often refer to
de faire nos propres choix.
bodily
Donc,
independence, making your own choices, and I think it comes back to that. Whether it be for abortion or gender affirming care, the reality is
dans une logique de est-ce qu'on donne ou pas accès aux soins. La
that
logique, c'est de
the
savoir
issue is
est-ce
not
qu'on
to give or
va
not
donner
access to
quels soins
care.
et comment on va
The
accéder à ces
issue
soins-là. Est-ce
is
qu'on leur donne accès à
what
ces soins-là
type
via
of
leur
care do we want people to be
par
able
le
to
marché
access,
noir, le
or
marché
do we
gris,
want people
ou
to
est-ce
access
qu'on
care
veut, puis de façon
via their own means
contrôlée, pas
on the black
sécuritaire,
market
est-ce qu'on veut que
or
les gens
in an
aient accès à des
uncontrolled,
soins
unsafe
d'une
manner,
façon
or do we allow them
sécuritaire,
to
d'une
access
façon
care
qui
in a
est
safe,
conforme à des normes
supervised way
cliniques.
that complies
Et
with
donc,
clinical
là
standards and standards
quand
of
je dis normes
care?
cliniques, justement, je parle vraiment de la qualité, par exemple,
And when I
des
say
hormones exogènes
clinical
qu'on
standards,
va consommer.
I'm talking about
Et
the
donc,
quality
la question
of
de l'accès aux soins,
hormones
c'est jamais
that are
de
going to be
savoir
taken.
si les gens vont y avoir accès ou non. La question, c'est
So
comment
the
on va y
question
avoir
is
accès.
not
Quoi
to
la qualité, puis ça va être
let
quoi
people have access or not. It's more about the quality of access, what type of care they can have access to. So we always have to keep in mind that when we challenge gender and trans affirming care, those are constantly challenged by many, many stakeholders. There's a legitimacy crisis right now, and we need to think seriously about it. We see it in the way the people are challenging reports that are published on the issue, because it is established that there's no scientific basis justifying the pathologization, if you will, of gender transitivity. And I think it's a fundamental fact that's unescapable. Recently, we've heard, specifically in Quebec, there was a documentary entitled Trans Express, in which many stakeholders were presenting trans affirming care as psychiatric care. And basically, a lot of people are challenging the care that's currently available, and people complaining about their children being forced to transition. Why? Because those parents had kids that had suicidal, and gender and trans affirming care was presented as psychiatric care. And so the parents agreed to that. They saw it more as an identity affirming approach rather than a gender affirming approach. So it was presented as psychiatric treatment, and that's how it is taken up by parents, and that's the way it's presented by professionals around them. And we need to seriously ask the question of how we want to ensure accessible care in a way that's not problematic for the people receiving them.
Thank you for that input. I do just want to remind everyone in the chat that we still are taking questions in English and in French. So feel free to add that into the Q&A feature. I'll be taking a look over them, and we'll be addressing them if we have time at the end. And I will do my best to make sure we do have time at the end. Next up, comment le passage affecte-t-il perception sociétale des personnes trans cis-normatifs?
How does passing affect cis views on cis-normative trans people?
I want to touch on this question. Well, I think that when we talk about cis passing, well, first of all, we need to be very careful with what we understand as cis passing, right? Because I have to agree with Florence that, the whole cis passing rhetoric was primarily invented by cis people. And it only benefits cis people, right? So, I think that when most of cisgender people think that the end of it all is to pass, well, that's very detrimental to the whole transparency itself. Because for me personally, what is it that I get by passing as a woman? What's the prize? To be raped? To be at a higher risk of being raped when I'm on the street? To be subject of sexual harassment? Like, what's the prize, right? So again, this is a very controversial topic within the trans community also. So, when we talk about passing, I think we really need to talk about trans misogyny that's linked to it. And again, I'm not going to repeat what I said about sexualization, but that's a huge component to it. So I might add something later, but just wanted to drop this here. What's the prize of passing as a woman? Nothing. We don't get a prize for being a woman in a patriarchal system. There's not a prize.
If anyone else would like to pop in on that, we can, and if not, we can move along. And I do have a question from the chat that we might be able to touch on. And what are your thoughts on detransitioning as an argument against gender affirming care for both children and for adults?
I have so many thoughts. So this is an area that I've done research and published on. So I've done research, empirical research, but also published works in collaboration with trans people and with people who detransition. And I mean, there's many things. First is like the freedom to only make choices that will never be regretted is not much of a freedom at all. The freedom to only make decisions that others approve of is not much of a freedom at all. And so the very idea of, having a right to be yourself, having a right to bodily integrity, to shaping your gendered self in a way that best fits you and makes your life more homely, one might say, that's not something that should be, taken away lightly. And the idea that the fact that some people regret is not a good enough reason until you can show that, one, it's a significant number of people, but also two, that you can prevent it. And what we know is that gatekeeping doesn't actually work at preventing regret. All it does is increase it. And bans certainly cause a crap ton more regret than they prevent. Now, I do think we need to do better in terms of like actually having care for people who detransition and things like that. A lot of doctors kind of see it as like a different thing, whereas in my idea, anybody who provides gender affirming care, it should just be part of it. And one of the big problem is, of course, this kind of transnormativity argument is sort of like, oh, you have one way to be trans. And when you internalize that, or when you're told that and your access to care is conditioned upon that, well, that naturally has a tendency to lead to more regret than if they didn't. So in many ways, gatekeeping is actively contributing to that. But then there's also the question of like, who gets to benefit from doubts? Who gets to have rights that aren't being overridden? Because there are so many important rights in society and so many things that people claim a right to that can have, negative consequences, negative results that can lead to regret. And yet we still think that it's an important part of life to let people have that freedom, because at some point, if we prevent everybody from making decisions that might have a bad outcome, then like we live in a totalitarian regime. The entire point of life is getting to make choices for yourself, even if sometimes doesn't exactly lead to the expected outcomes. There's so many things in my life that I regret. None of them happen to be gender related. But but it's made me who I am. It's just an integral part of living. And so I think this is something where, like, to the extent that there is doubt, that doubt should benefit trans people, should benefit people having freedom to do with their bodies as they wish, especially in a society that's so damn intent on preventing us from doing it because of their very narrow and constraining and ideological understandings of gender.
It's always about whose regret, right? Like who gets to regret and who gets to be right, at some point, like regret rates for knee surgeries. We talked about that a lot. It's a recurring talking point, right? It's just like people regret having like knee surgeries, but guess what? People are having knee surgeries because they feel that this might help them. And it's it's a very troubling way of framing the question, in my opinion, actually. Like this idea that like detransitioning could, it's like, it's always the center of it all. It's always the question, like, for whom are we trans? For whom are we transitioning, right? If you frame this as a doctor has a liability, as a responsibility, is in charge of this thing, well, of course they should probably, like have a very strong gatekeeping, to be sure that, because we're in this framework, we're transitioning for doctors, basically. But that's not the case. We're not transitioning for doctors. We're transitioning for ourselves. And so at that point, since it's a very personal, very private endeavor and process, I mean, you try stuff, you fail, you revert back, you try something else, some type of haircuts I regretted, and I felt that they were making me very like it's just like, for whom are we transitioning? I think this is the core of it all. It's the crux of it. If as long as we consider that the doctors are the center of it and that we're transitioning to appease doctors, we will be framing this as like we will be framing gatekeeping as a core issue of like trans-affirmative care. But like if we start thinking about a process that is personal, that is individual, that has perhaps not a lot to do with medicine, all in all, then we will walk away from gatekeeping. It's just, yeah.
Yeah, I do agree with both of my colleagues. I really want to emphasize or talk about the medical liability in this whole situation. So when we're talking about minors and regrets and stuff like that, well, we also need to talk about, again, to the whole gender norms and expectations that the medical institution kind of pushes onto us as trans people as well, or even non-trans people. So if you have a parent of a or a guardian of a minor who's maybe a 10-year-old, I don't know, and has a sense of discomfort with not, okay, not the gender that was assigned at birth, but probably a discomfort with the whole social norms around a certain gender, which is different. Again, you could be a man and like Kurt, or you could be a man and like to play dolls. It has nothing to do with the gender identity. Again, but when we take this minor to a psychiatrist or primary care physician, and the guardian talks about this feelings that the minor is expressing openly to them, and if we have a provider that says, okay, we are in front of a trans youth. How do you know you're in front of a trans youth? Okay, so that's my biggest issue with the whole um gender affirmative care. It has its benefits, but it could also be detrimental in the sense that we cannot just be throwing diagnoses onto people just because they don't agree with the gender norms, or just because they're showing a consistency in their way of expressing gender. So just wanted to put it out there. If you start to push blockers and hormones and all that stuff onto a youth that might not be trans, just maybe they were gender not conforming in a way, well, there's a higher risk of that person having regrets later on in their life. So yeah, this poses really interesting questions in terms of ethics. And it also comes back to the medical liability. So what are we doing? We need to be very careful with trying to push the trans narrative onto youth that might not be trans.
I think ultimately it's about, doctors and, society more broadly, not making clear to everybody what is possible, but not pushing that onto them, not pushing narratives onto them, right? I'm thinking, so my next book is on science and trans youth case law in Canada. And, one thing we see is this kid being labeled a trans girl. And it's pretty clear from all the information there that this kid is some shape of trans, but a lot of the statements are like perfectly compatible with the kid being non-binary as well. And they're just and they have this tendency to kind of like impose this very binary frame. And also, consistently across the cases, doctors just being completely clueless about non-binary people and imposing their own understanding onto kids. And that's where the trouble lies, right? Like it's ultimately, it comes down to a failure to listen. a failure to hear these kids. They're not sitting down and trying to understand what the kid is saying. And, and the fact is, kids speak in the language of kids. They don't speak in our language. And so we have to learn their language and we have to learn to understand them. And instead of doing that, they're more busy trying to slot the kids into their categories. And that's where, a lot of stuff can go wrong. And frankly, it happens with adults too. How many people get pushed into a very kind of narrow understanding of being trans, and only to kind of realize later, well, that I'm fully fit. Or even me, who I knew I was non-binary from kind of the start, but it was just so much easier to access care and to access a bunch of things by just being like, oh yeah, I'm a woman, and having this very kind of simple narrative. And then the moment I got everything I wanted from doctors, I was just like, I can stop that now, and so we need doctors to hear people. We need doctors to be there as a support, not as an evaluator, not as a gatekeeper, but and one of the things I like to talk about in my bioethics work is the concept of scaffolding. People's decision making. Yeah, sure, you have this idea of informed decisions or this thing you take kind of in isolation, and you're kind of by yourself, and it's completely free from the other's influence. And yes, you don't want other people to kind of impose on you, but we can help and support people's decision making in so many ways, by helping them explore, by helping them understand themselves, but also by reducing the negative social pressures and messages that are in some way negatively impacting their thinking, their decision making. And so we have an important role to play in that. And, a lot of time just having a soundboard that's not judging you and that's not gatekeeping you is really helpful, because there's nothing that's less helpful to people figuring out what they need than being afraid that the person in front of you is gonna say, no, you don't get care.
And I think this is this relates a lot to the question of what's the for example, we have a question in the Q&A from Vanessa about what's the role of an ethicist in that, how are we putting how can ethicists just put an additional layer on top of the gatekeeping that already exists, right? And I think that if we have this very more encompassing and looser approach to what it means, what care means, rather than just being oh, this is the pill you need, or this is the therapy you need, or whatever, and just being no, actually in this context, taking care is much more encompassing, much larger, much communal based too. We have to get trans people in schools. We have to get communities closer to the youth. We have such a hard time getting in contact with one another through generations, because we always keep us separate, because they don't because adults are so scared that we would influence their poor little kid. They want them to be isolated and take this decision by themselves, with the professionals. And that's just not how it works. I think they need to be influenced, they need to know about how shitty it is to be a trans adult too, and how little access you have to the workforce, and how little how prevailing is violence as well. And because in the last years especially, I think that trans youth have been pushed a very rosy glasses understanding of gender, and push this idea that yeah, you have an identity, you can be whoever you want and everything, and they take very unconsidered risks as well, because they don't understand the social context in which they are affirming their identities, and then they are exposed to more violence that they cannot make sense of, because they are surrounded by cis adults. And so there has to be a wider understanding of care that includes the community as at large too, and I think this is a very, very important question that Florence is raising right now, you know? And like regarding the role of ethicists in that context, I think that we always have to keep in mind that the first article of the Hippocratic sermon, what is it? Oath, yes, is do no harm. It's just that, like harm reduction, like just be kind, be understanding, be like subtle, be more, you know, like more compassionate as well, you know, like because we have been put, and the kids right now are put in this very, very precarious and very difficult situation where they are evaluated in a context of rising hate and rising hostility. And they're isolated in like social medias, and they're isolated in very, very like small bubbles. And I think like we need to like broaden their perspective and their support like from outside actually of the medical profession.
Actually, I want to jump in.
Yeah, of course, Florence.
Yeah, because also like I think like there's been a lot of issue, like I'm thinking notably in the UK in terms of like the way that they were using like discrimination against trans people as a sort of like scare tactic with youth and very victim blamey thing. And then there's been a lot of opposition to that, very rightfully so. But you know, there's a difference between victim blaming and scare tactics and informing people. And even if it's not the sort of thing that will ultimately impact their decision, you want to know it because you want to prepare for it, right? Like regardless of how, you know, it may or may not impact your decision, the reality is you don't want to be like shocked that that there's hatred and discrimination in society when it comes up to you. You want to build resilience, you want to build support, you want to build community, and you don't do that through isolation. You don't do that through people like not giving you information. So yeah.
Yeah, and I wanted to touch on you know, some of those kind of topics that we were talking about in terms of broadening care, and what it means for you know, a wide and diverse kind of range of healthcare professionals to be involved in those kinds of care. And I think shifting kind of gears onto something that's a little bit more specific to ethicists. Thank you for all the bioethicists that are in the chat, letting us get to this. But how do you think that clinical ethicists should respond to professionals or parents who are not sure about how to provide care, especially in under-resourced areas? And, you know, what kind of things do you see lacking in terms of training or support for those kinds of people in terms of providing ethics guidance or providing care?
I think, oh yeah, that was
I mean, you can go if you. Okay, I'll start.
We'll let Florence and then Judith.
Sure. So what's the role of an ethicist? I think, frankly, a lot of time when you're an ethicist and providing consulting with like to a physician, a lot of it is going to be about fighting gatekeepers, whether it's that doctor or other people. A lot of it is also going to be dealing with parents, especially when it's like youth, is just like and that's where I think like especially like narrative ethics is particularly useful in terms of like getting them to like, it's very normal for parents to have feelings. The problem is that they tend to dump them onto the kids, and so like helping them process them in a way that like doesn't get unloaded into their kid is like really helpful. You know, like when I transitioned and I was an adult, my parents went to therapy, but frankly, they didn't tell me, and that was good. You know, like still a little bit of splash damage, but you know, in a grand scheme of things, it wasn't too bad. So that's an important thing to do that with them. But then the other part is to like listen and advocate. That's part of fighting gatekeepers, but also part of just like support. You can be that person who does the scaffolding. You can be that person who learns the language of the person, especially if they're kids, and you know, brings the information to them that they need, connects them with the people they need to be connected to, gives them resources, gives them understanding. You can be that for them. So instead of increasing gatekeeping, increase their autonomy, increase their resources, increase their capacity to make decisions for themselves and to explore their gender if they're still in that, you know, stage. And I mean, I'm still a big proponent of like exploring gender as a lifelong thing, even if it's every morning waking up and being like, yep, still the same. But you know, or if you're me waking up every morning and be like, yeah, still don't know what the fuck is going on. So yeah, I think that's my vision of like the clinical ethicist role there.
Yeah, that's basically why I wanted the ethicist talk first.
Did you have anything to add to that, Judith?
I think the only thing I would add to that is like I think not only ethicists but like in general like people in the medical professions should be aware that nobody knows what the fuck is going on. Like the information that we have right now is so sparse, and like the research that has been done on gender affirming care is so focused on like dangers and like liability of professionals, and like we don't like there's not a lot of data, if we're honest, about like the most efficient path to the most to this or this result, for example. Like there's no protocols. Like every doctor just goes like kind of just wing it, right? It's just like um and that's the reason why, as a community, as communities, I should say, trans people have built a tremendous amount of resource and knowledge about what it is to transition, and that's probably the reason why I would advocate for the community to be more involved. But when it comes to like providing care, it's always about, you know, people, you like I think Florence puts it very very nicely, you know, like just getting people to understand that, you know, at some point you got to go on with the flow, right? Like you can hold back, you know, like you know how like for example puberty blockers, like very contentious topic, right? But puberty blockers were basically developed as a tool for gatekeeping, you know. It's now like something that kids might want, actually. Like it feels good for them, and like that's nice, it's a new tool. But if it's just imposed from the outside and just like, oh, you cannot be sure now, oh no, you surely cannot know, we'll put you on puberty blockers until you can have like a sound mind and you're able to actually make a decision by yourself on that topic. It is detrimental. It is detrimental to the kids. And like, especially puberty blockers should never be seen as a middle ground. And that's something I would emphasize on, to be honest. It is not a middle ground. It is something that should be um, like coming from the youth and not like being like just a way to avoid like having to make a very definitive decision, because it's not a it's not a definitive decision, you know. We exist in time. Like we're beings that exist through a timeline, through an entire life, and we will change, and we'll change our view of ourselves, our view of gender. It's all right. And like I think that both kids need to hear that as well, you know. Parents, a care provider, but also like the trans youth has to learn about that, because right now I think that they are under a tremendous pressure to be super like solid and clear cut in their decisions, and like because you have to fight back against such a harsh environment, both political and cultural, and like we have to get the pressure down on them and just like let them know that, you know, you have your whole life going through that, and that you can make decisions, you can revert back, and we will be there for you. We'll be there to accompany you, and you are at the center of it. You have power over yourself. That is something like care should be empowering for kids.
Yeah, I would just like to remind the chat, we are about 10 minutes away from the end of this presentation. So if you have any last minute questions, make sure you pop those into the Q&A feature on Zoom. We'll take a look at them, and if we have time, we will get to them. I just want to ask one last question. I know April's excited to answer this, so I'm going to pass it over to you first. But how do you shape your activism to address the exclusion of trans people in society and in politics and things like that?
Well, I think the way I do it, or the way we do it as MTF movement, is by prioritizing trans women focused spaces to address the specific material conditions that trans women face. So for me personally, my activism, instead of, uh, being too focused on the identity politics, that's very broad nowadays. There's the constant need to talk about pronouns, and that's fine. Like there's like a certain branch of trans activism, but that's not my branch of trans activism. So because I come from a feminist background, and I'm also a Marxist feminist, first and foremost, um, I think we also have to defend our rights and solidarity with liberation struggles. So I firmly believe that no one's free until everyone's free. And that's something that I hold dear, and that I, try to defend and push onto every single space that I'm invited to. So that's why upholding internationalist and dialectical materialist approaches is crucial, because it allows us to highlight how our reality are as trans people are not only interwoven with those of the working class, because we're also working class individual before being trans, right? We're working class in this very hierarchical relationship, power relationship. And also in solidarity with those of the racialized community, because we're not only trans, and that's the whole issue with the liberal discourses. We're not only trans. Me, before being trans, I'm a Latina. I come from a racialized um, continent. So when I enter the global north, I'm not only seen as trans, I'm seen as an immigrant, I'm seen as Colombian, I'm seen as, so there's so many layers to it that also shape uh, my reality and the reality of our community. So I think that's very important to address these material conditions that produce these disparities in first place. And finally, I think this is my closing words. These are my closing words, if you allow me to. Now, if we look back at our struggles for justice and equality, we will then realize that we have always been confronted by ways of conservatism and fascism. So this is not new to us. I did get the sense of urgency that most of trans people in the global north are experiencing, but we as Latinas and we as trans people from the global south, we have always we have always lived in a constant state of distress. So it's like you don't really fear losing something when you never had it in the first place, right? And that's how we trans people from the global south go about it. So, uh, while we cannot create the conditions for the struggles in which we engage, we can definitely bring our determinism and our vision for a better future. And that's what I think can just we as trans people from the global south can bring to the discussion. We have never relied on we have never relied on the medical institutions to access care. We have each other, and that's the most important thing.
I can go next, I guess. Frankly, my activism has changed a lot since moving. I was a lot more kind of connected in community on the ground in Montreal than I am in Alberta. Now that I'm like a prof and shit. Ugh. So what do? I don't know. Apparently, I'm sure the right-wingers would say I brainwash my students, which I think is a very important part of my activism. Sometimes one way is to, you know, get drunk with leftist politicians and you know, try to get them to do good stuff, or get drunk with right-wing politicians and then blackmail them. I'm not saying I did any of those things. I'm just saying that's one thing you could do. But then there's just like the solidarity aspect. Like we need like to build solidarity across difference and across struggles, because like frankly, I mean, how are you gonna convince people that trans people should have rights to medical care when you can't even convince people that, you know, mass bombing Gaza is bad? So, you know, I think there's that aspect. There's that aspect of like needing to, you know, not be only focused on trans struggles, but link different struggles and also show up for struggles that we don't think are necessarily linked. I mean, they are, but even if you can't see it, like it's important to show up for everybody, because well, how are you going to convince people to show up for you who aren't trans if you don't show up for, you know, other groups?
I think this is the crux of activism for trans people right now. I think that there was for a long time, you know, transgender movement specifically. I consider myself transfeminist, and so I kind of differentiate the two. But transgender movement since the 90s has been very focused on like very corporate, like very like, oh, we need to get that right, we need to get that right, and just like progressism, you know, just getting closer and closer to like basically the universal whiteness, and like that's basically it. At some point, like there is this sense of disconnect sometimes in the transgender activism circles, because you see people clinging to a lot of privilege in the end, when at the end of the day, when I look around me in my community, what I see is migrant women, what I see is sex workers, what I see is people with mental health issues, what I see is people with disabilities and stuff like that. And like when we say that all struggles are linked, it's not like an abstract. It is like our communities are made of this very diverse set of oppression. Like it's not something out in the air, like we're talking about Gaza. I think like just yesterday we had I think like 4 or 5 doctors just being like, please hear us, you know. and and you know, we have Palestinians in our own communities, we have Jewish people in our own communities, and all these people are saying to us like, we have to stop this genocide, we have to stop this massacre right now. It is like, we're not like in trans people are not an abstract. Trans people are actual individual, actual people. And when we engage in activism, we should engage as people, you know, and people who are poor, people who are working class, people who are isolated, people who are crazy, like mad, you know. We have to get that all together. And if we just isolate, you know, trans issues like it's some abstract, we're just basically putting all our energies into benefiting a very small subset of our population who are always the same, you know. And that has been the case for so long at this point. And we have to switch. We have to get into this coalitional approach. And that's what we're trying to do right now.
Thank you all so much for all of the things that were spoken about. I want to thank everyone in the chat for sticking around. And I just want to pass it back to Meredith. And just before I do, I just want to let everyone know we do have a list of resources that we had kind of come up with. So those will be all sent out to whoever registered. And I think Meredith can give a little bit more on that as well.
Yeah, I will send the list of resources that we developed in partnership with our speakers to those who have registered for the forum and for this special conversation series. I believe we have resources dealing with the whole of the Americas, because April has contributed some resources specific to the South American continent, because George and myself focused on the North American continent a little bit much. So I really want to say thank you to our speakers and our moderator. I think you did an amazing job, and I'm sure all of us have learned a great deal from you. And I have a bit of housekeeping for those participants who are also part of the forum, which is there will be a 15-minute break, and then there will be at 4:45 Eastern time, we will rejoin on the Zoom link for the forum, not this Zoom link, to participate in the recording of the podcast Pop Bioethics. And we will open that link up in just a few minutes after I say goodbye to our panelists and technological support over here. So looking forward to seeing some of you. And if you are just joining for the conversation series, but you would like to continue to learn about bioethics, you're welcome to register for the forum or become a member of the Canadian Bioethics Society so you hear about all of our events. Thank you. Bye-bye.